Yes, we can.
Yes.
Yes, we can see the slides as well as we can hear you.
Okay. Just a moment. Is okay? Dear colleagues, do you hear me?
Yes, you can start your presentation.
Dear colleagues, I am Pirogov Russian National Research Medical University. I'm from Moscow, and I am a radio and research in radiotherapy and brachytherapy in oncogynecology cancers. So my presentation is concerning the clinical results of radiation and chemoradiation therapy of locally advanced cervix cancer. The latest statistics for Russian Federation shows high incidence rates of gynecological malignant tumors and increased cases in young women and increased cases of aggressive forms of cervix cancer. On the slide, you can see a top female cancer rate in 2020 in Russia, and you see that the cervix cancer is on the fifth place in the structure of the female new cancer cases, and it is 5.2%. The increase in the standardized rate of cases from 2010 to 2020 was about 11%. Most often, cervical cancer is detected at the age of 30 to 40 years, and it is about 21% per 100,000 population, and usually diagnosed locally advanced cervix cancer stage second and third. A complex of modern methodological approach of conformal radiotherapy combined with image-guided brachytherapy are used for the treatment of this kind of patients. Image-guided brachytherapy has been widely adopted after the publication of the joint American Brachytherapy Society and Group European Curatherapy and the European Society of Radiotherapy Oncology recommendations, which we used in clinical practice through the last 15 years. It is the priority method for the treatment of the cervical cancer patients. Regardless of chemoradiotherapy considered to be the method of choice of the treatment of locally advanced cervical cancer, it is radiation during weekly use cisplatin, concurrent cisplatin. New cytotoxic drugs regimens are different types, and different types of administration during radiotherapy are developing in order to improve clinical outcomes. There are some interesting studies where cytostatics were used in the form of doublets. Irinotecan and cisplatin, paclitaxel plus cisplatin during external beam radiotherapy, and adding adjuvant therapy after chemoradiotherapy of cervical cancer. The aim of the treatment is a decrease of tumor activity and the destruction of micrometastasis for prolonging survival. Remember the cell cycle. It is known that during the mitotic phase, cells are the most radiosensitive, and during synthetic phase, least sensitive. Cisplatin does not have phase specificity and acts in J0 phase of the cell cycle. Irinotecan, acting mostly in S phase of the cell cycle, additionally affects tumor cells. Paclitaxel is a phase-specific drug which acts in interphase and mitotic phase and helps to achieve full exposure on a tumor. Available world literature data confirms such theoretical approaches and reports a significant increase in progression-free survival, overall survival of patients with locally advanced cervical cancer and compared to monoradiotherapy with cisplatin. Thus, based on theoretical knowledge, we conducted a single-center clinical study with the aim to improve the survival rate of the locally advanced cervical cancer patients with modern radiotherapy technique and combinations of cytotoxic drugs. The analysis of overall and progression-free survival rates, time to progression, recurrence rate, as well as frequency and degree of radiation toxicity and complications were performed in the study groups of cervical cancer of young patients. The clinical study contains retrospective and prospective clinical data for the period from 2011 to 2015. It was 190 patients with locally advanced cervical cancer who received radiation therapy or chemoradiotherapy were included in this study. The patients are divided into groups according to the new techniques and randomly selected into 4 groups. You see on the slide that group A was consist from 72 patients, and it was simply external beam rate radiotherapy plus image-guided brachytherapy. Another group B, it was also the group A, it was a retrospective analysis, and group B also retrospective, consists of 40 patients where we use external beam radiotherapy with concurrent cisplatin plus image-guided brachytherapy. Group C, it is prospective group with chemoradiotherapy with duplet irinotecan plus cisplatin. The scheme you can see on the slide. During external beam radiotherapy plus image-guided brachytherapy, and then 2 courses of adjuvant therapy with these doublets on first and 8 days was done every 21 days. And group D, also prospective, with 39 patients, doublet of chemotherapy was paclitaxel plus cisplatin during external radiotherapy plus image-guided brachytherapy, and then 2 adjuvant courses were done with these doublets. The scheme of radiotherapy similar to all patients. It was external beam radiotherapy with conformed technique. The total dose was 50 grays per pelvis, 2 gray per day for during 5 weeks, and then it was image-guided brachytherapy with prescribed dose 7.5 gray for per week, 4 fractions, to a total dose of 40 gray according to UKD2. The clinical study, according to the analysis, which receive only radiotherapy, the group A was the most favorable from a prognostic point of view. It was 63% of second B stage cervical cancer patients, 68% with 68% with 3B. Regional lymph node wasn't found in 61 patients. Other groups was where we used chemoradiotherapy at the most unfavorable prognosis. So in group B, we included 62%. Group C about 72%, and group 69%. The percentage of lymph nodes involvement was 52, 51, and 46 respectively. The mean age of people was below 41 years. The analysis of histological structure showed that squamous cell carcinoma was prevalent in all groups. However, there were 10% with adenocarcinoma in the group D. It appeared to be 41% of moderately differentiated and 36% of fully differentiated tumors among the all cases of squamous cell carcinoma in Group C. Group D contained mostly cases of fully differentiated squamous cell carcinoma. It was about 15%. The average duration of a radiotherapy course was about 60 days. The average total dose to the cervix was about 95 gray, and doses by groups is presented in the table. The results of the whole group of 190 patients of cervical cancer who received radiotherapy and chemoradiotherapy were analyzed, taking into account frequency and time of recurrences and distance metastasis and survival rates. The median of observation for Group A was about 40 months, Group B 41 months, Group C 35, and Group D 31 months. The results of tumor progression study don't demonstrate the decrease in number of distance metastases in groups with combined chemoradiotherapy. They were, as you see, they were 19% in the first group, 20% in the Group B, and 20% in Group C, and 31% in Group D. Most frequently, metastasis appeared to be in the para-aortic lymph nodes, liver, and lungs. It is noted that radiotherapy with combined chemotherapy, which was added with adjuvant courses, allows to increase the time to progression nearly twice in the most prognostically unfavorable groups. For Group C, up to 19 and a half months, in Group D, 60 and a half months, compared with Group A and B, where time to progression was 9.5 months, both for these groups. 3-year local control among all 190 patients was 95%. For groups A, B, C, D, it was 19, 100%, 55, and 100%, as you can see on the slide. The decrease of the local recurrence number was noted in Group B and D for 9.7% compared to Group A. For each of Group B and D, and Group A, yes, thank you, sorry. Survival analysis in 190 patients with cervical cancer, regardless to the stage, did not reveal statistically significant difference in 3-year overall survival and progression-free survival in groups that you can see on the table. Overall, comparative analysis of survival rates in patients with with 2B and 4B stages cervical cancer was not performed for small subgroups. This analysis of survival rate was done only for subgroups of patients with 3B stage, because this subgroup was the largest in the study. Analysis of overall survival in patients in this stage didn't reveal statistical significance increase depending on the treatment regimens, and this data you can see on this table. If groups in groups B and D, progression-free survival rates in patients with stage 3B cervical cancer during first year of observation was 79% and 89% respectively, and did not significantly differ from Group A, where it was 74%. However, progression-free survival in Group C during the first year of observation appeared to be higher to Group A, and it was 96%. versus 74%. Respectively. Statistically significant difference in the results was not revealed over next 2 years of observation. As you see in this table. Statistically significant differences was not observed when comparing a 3-year progression-free survival in group B. It was 74%, and D, it was 69% compared to group A. It was about 60%. Thus, it noted that chemoradiotherapy regimes combined with irinotecan plus cisplatin, followed by 2 adjuvant courses, allowed to increase time to progression for patients with stage 3B cervical cancer. Analysis of survival rates, depending on the degree of the squamous cell carcinoma differentiation, was performed. Small groups of patients excluded from the study. 3-year progression-free survival of patients with moderately differentiated squamous cell carcinoma was 90 in group B and appeared to be higher than in group A statistically significant improvement a statistically significant improvement in 3-year progression-free survival in subgroups which contained patients with poorly differentiated squamous cell carcinoma of the cervix was found after analyzing in group C. It was 81% compared to group B, 42%. Significant advantages in progression-free survival were not obtained for groups A and D. Some words about complications. Average time to complications didn't statistically differ in groups, and it was ranged from 10 months to 16 months. The frequency of grade 1 late blood toxicity was from 5 to 5.6% in all groups. However, Group C and D shows a tendency to increase in the frequency of grade 1 and grade 3 toxicity compared to the group. It was 15% of patients identically in group D versus 4% in group A. This is probably due to the manifestation of cisplatin nephrotoxicity, as well as potentiating action of the 2 drugs on the bladder mucosa. There were no statistically significant difference in the grade and frequency of the late proctitis. Nevertheless, attention is drawn to the frequency of hemorrhagic proctitis detection in all the study groups. 11% of patients in group A, 12.5% in group B, 10% in group C and D. For cases of rectovaginal fistulas were detected 3 patients in group A and 1 patient in group C. So, in conclusion, I can say that our study demonstrated a fairly aggressive treatment for cervical cancer in a group of young women. We have received high treatment results using modern radiation therapy technologies, and chemotherapy with irinotecan plus cisplatin showed promising results with acceptable toxicity. I think that immunotherapy trials for cervical cancer may help improve treatment outcomes in future. Thank you for your attention.